All right, so I remember when we were doing the hip last week, I kept on looking for good images for the musculature, and then I'm looking through this chapter 19, and they have really good images of the musculature. So when you're as you start to when you start studying for the exam, you'll be exposed to these, and you'll see how the ankle and the muscles of the ankle have some carryover from the knee. The muscles of the hip have some carryover from the knee. The muscles of the pelvis carry over into the hip, and then as we get in the spine, so we isolate these joints down into their smallest function. But when you take a step back, they are integrated, and the muscles do cross over. So don't feel overwhelmed when you get into these, especially with the lower extremity. You study in the musculature of the knee, you're inadvertently studying the musculature of the ankle and the hip as well. And they have a distal and proximal aspect, but there's overlap. So they're all integrated together, and the function of the muscle doesn't necessarily change when it goes to a different joint. It just produces a different joint action. But the attachments and origination and everything is the same. When we look at the knee, actually most of our attention is going to be on the non-contractile units. It's not going to be on the muscles themselves. Like I said, when you study the ankle and you study the hip, there's a lot of overlap with the muscles. But with the knee, the architecture of the knee, because of the ligament structure, the cartilage, and the mechanics, we actually get more into that than we will in any other part of the lower extremity, minus the foot and ankle, depending on how complex we get into those joints. But so we got this concept of these osteokinematics and the arthrokinematics with the joint motion, and you have your tibia plateau, which is relatively flat. It's actually really flat, and what gives it any kind of substance is actually a meniscal cartilage that exists there. You have a C-shaped and a D-shaped ring that sits on there, and then you have your articulating surface of the femur, and you have this huge surface here and this somewhat smaller surface there. You can see it's almost 60% larger. And when we use the knee a lot in the example, if you remember from the first unit when we were talking about arthrokinematics, the roll in the slide, we use it as an example because if you're stacked up here and you roll backwards and there's no associated glider roll, you would actually be off the edge of the cliff. And same thing here, if you're flexed and then you go into an extended position, you're distracted, you have shearing force this way, you're coming straight down. So as that axis of rotation that's right there, there has to be a simultaneous movement of that in order to keep those aligned. And this is very prevalent with the knee. It's the most important aspect with the knee because of that optimal congruency. So you have this roll and glide mechanics that are happening to try to keep this stacked up on each other. So you have the load of the femur coming straight down, receiving there in the force. So we have femoral on knee movement, and we have, femoral on tibia movement, and we have tibia on knee movement. So if we have an open chain aspect, so let's say you're seated and you're doing knee extension, you're going to have that concave on that convex type movement. And so as I'm moving up, as I'm going into extension, I would be jamming up there, and I would need a forward force that way to kind of clear that. So you'd be gliding and rolling in the same direction. And then same thing's true for knee flexion. As I'm coming down, I'm going down in this aspect. I need to move because this is the convex surface, the distal end of the femur. This is the convex, this is the concave. Now, if I have femoral on knee situation, so let's say I'm standing and I'm doing a squat, as I'm doing knee flexion, if I were to flex back, you could see that I'm going backwards, I'd fall off. So I actually need an opposite movement. I need a gliding force in this direction so that it stays congruent. And then if I go into extension, if I don't have those linear forces, if I were to extend up, I would fall right off the edge. So as I'm moving up, I'm gonna pull backwards so I have opposite direction. So just keep track. The knee is probably the biggest aspect for these arthrokinematics, looking at a roll and glide and making sure you know which direction. The other aspect that you have within the knee is you have transverse plane motion, which you have internal rotation and external rotation. So if you have your knee bent 90 degrees, and so this is a right leg, and here's my tibia. If most of you guys are sitting right now, except for Doug, it looks like you're laying down, like you're relaxing there, but you're in knee flexion here, and you turn your toe outwards, you're going to get tibia rotation. So you're going to get this type of torsional movement, this twisting here. So you actually have quite a bit of movement. I mean, quite a bit relative to the transverse plane, but it's a overlooked movement that happens at the knee: internal rotation and external rotation. Actually, I did the opposite. That's external rotation and internal rotation. As you lock your knee out, it's hard to isolate tibia motion, because when you move here, you actually have a lot of femur internal external rotation. So when you try to do leg extension and you turn in, most of that motion's coming from the hip. But if you bend your knee, you can really isolate that tibia internal external rotation. And then there is no sagittal plane motion. So there's no frontal plane motion. Any frontal plane motion here results in a MCL or LCL tear. So you usually don't get that gapping. The other thing to consider, this is actually not anatomically correct, it's actually a little bit. Well, let's hold on the Q angle, but that's with this slide here is kind of looking at those relationships with the flexion and extension, which heavily involves the arthrokinematics. And then you have, from an osteokinematic, you have internal external rotation of the tibia, and it's going to be most present in knee flexion, not with knee extended. You can see here, this is a distracted view, so you're looking up from an inferior view, and you can see that the medial condyle is slightly larger than the lateral condyle. You can see some of the twisting, the internal tibia rotation, and this is called the screw home mechanism, and this is dealing with like the locking, unlocking. I have to look through the text and see if it pops up, but I know I go into detail on that in my lecture videos about that locking, unlocking mechanism. But let's hold for that now. What I want to talk about here is the size differential between the medial condyle and the lateral condyle. I'm just going to scroll down a little bit here, and then we'll back up. You may or may not have heard of this thing called a Q angle. And the Q angle, the Q stands for quadriceps. And this is the quadriceps angle of the line of pull that goes to the patella. And why this comes up a lot, this is in the developmental, like 18 to 22-year-old for females, there's a high occurrence of ACL injury, MCL injury, and they attribute this to the anatomical difference that exists between males and females. And so women have a larger pelvis slightly for childbirth. And then what that does is that if the pelvis is wider, it's going to take the femur and it's going to push it out a little bit. And so if the pelvis is wider, you're going to get a, I don't know if you can, let me see if I can back up a little bit so you can see the whole aspect. If the pelvis is wider, you're going to have a more acute angle coming down into the knee. And so what they say is happening is that this wider Q angle puts more pressure or stress in here. And I don't know if you guys have gotten through this whole valgus versus varus conditions yet, but if you were to look at, let me pull it up real quick because it's easier to, and I know I talk about it in the videos here, but if you were to analyze the appendicular skeleton, and you don't really see this too much in the upper extremity because we're non-load bearing, but if you can appreciate, let me see if I can get a better image. Yeah, this one. So if you see here, you can see that the proximal end of the femur is more lateral than the distal end, right? So you kind of have this V-shaped. If you were to extend these lines down, I can do that. If you were to extend these lines down, you'd have a V shape, right? So you have a little wider aspect here. And females are going to have even a wider V at the top than males. And when you analyze the proximal end versus the distal end, you can have situations where you have this is more acute, where this is coming in more or actually coming out more. And if you have a gap or the distal end is wider than the proximal end, that's called a Varus condition. And the best way to remember this is that Varus rhymes with air. And so air can pass through there, right? So if you have like a gapping here, there's air that can get through. That's a Varus position. If you have a more acute angle where it's coming closer, that's going to be a valgus. And the only way, and this is how I keep track of it, I'm just sharing with you my brain. I think of gum, valgum, and like the knees are stuck together. So you have varus and valgus positions where you might be more clinically what they would call, non-clinically, but more street terms would be bow-legged, or if you have a valgus condition, you'd be knock-kneed. So when you compare males versus females, because of that wider Q angle, there's going to be a bigger valgus condition at the knees, or a bigger varus condition at the hip. So you watch the video and we'll go in more detail for that, but you have to consider, are you talking about the proximal end or distal end? But if you're in this situation here, you can either be varus at the hips because you have more space or gapping or more air can get through, and you're valgus at the knee, and then you can also have a concurrent either varus or valgus at the ankle. So you're analyzing each joint. Just saying that this is varus is not looking at this whole system of the hip, knee, and ankle. It's just looking at the condition at the knee. And all that is saying it's varus is that the distal end is wider than or more lateral than the proximal end. And if it's valgus, that means that the distal end is more medial or closer than the proximal end. Do you guys need me to repeat that, or does that make sense? Okay.
You were saying if there's a wider Q angle, then that's valgus.
Eric, you're just is everyone else hearing Eric as distorted robot? Okay, so can you check your mic real quick because your microphone sucks. There could be some magnetic. It actually sounds like interference. Oh, you're going to redo your earpods.
All right. You were saying that a wider Q angle is giving a valgus angle?
Yeah. So when you look at, so you can see here that just normal structure, regardless of looking at male or female, you can see that the normal presentation is that the distal end of the femur is a little bit more towards, let me draw a midline here, is more midline, right? You can see that if I measure the distance there and the measure distance there. Now, the difference between males and females is that since women have a larger, they have a larger pelvis, like that opening's bigger, that this distance here is actually going to be out a little further. And so that's creating, and what I had said was you're creating either more varus at the hip, you're creating more space, which then would result or could result in more valgus at the knee. I just keep track that it's varus and valgus is relative to each joint that you're referring to.
All right, thank you.
And so what this does, let's see if I can pull up a better knee position. Let's look at the collateral ligaments in the knee. Let's actually go back to that. Okay, I like this image here. So you can see that just naturally in a normal condition that the load going into the medial condyle is actually going to be a little larger than the lateral condyle because of that angling. And that's why if we go back to the textbook, you'll see that the medial condyle is larger than the lateral condyle because of that increased loading, right? So if you look at the bottom of, if I look at the bottom of a femur, you will see that the medial condyle actually is more protruding, picks up more, and that if I were to lay this flat, it actually angles out a little bit to accommodate that hip width, right? And so when it's articulating with the tibia, there's more contact area that needs to happen there, right, to make up for that gapping, that differential. And if I increase that varus or valgus, if I change that angle much, let's go back to that image. Let's go actually here because you're able to see it better. No. It's not the image, it's too grainy. Yeah, we'll use this one. So if I go too far in now, because this is too wide out this way, I can start gapping or putting too much pressure. If I take this system here and I go wider at top, can you see how this is being put on? Any tissue that's holding that would be stretched out, would be put under tension. That gapping is happening there. And so this is where you have the medial collateral ligament, and on the lateral side you have the lateral collateral ligament. And if I have any type of either impact that way or any kind of loading this way, I can put too much strain there. And if I look here on the tibia, there's no connective tissue there, but I have meniscus there. If I'm widening out this way, I can be putting too much pressure on that lateral meniscus, or some damage through the menisci that can be causing more pressure. And so when they look at and then you have the ACL, which we'll talk about in the sagittal plane motion, that kind of comes down and connects down here with the in the plateau. That because of this wider angle, responsibility here to hold us together, that is what attributes to more of the ACL occurrences in the younger female athlete. So that's where this whole Q angle comes in. This is all like anecdotal evidence, because most of the literature that's coming out, it's not even new stuff. This is like in the last decade now, has been showing that Q angle really isn't that big of a deal. The problem is when you look at, let's do this quick. Let's look at, perfect. Okay, so here you got your right leg, and when you see this, I know we think of pronation, supination. We talked about that as wrist motion, and when we get in the foot and ankle, we'll be talking about pronation and supination all day. And basically, pronation and supination it means three different things. It means wrist position. It means the status of the arch. Do you have a supinated or high arch, or do you have a pronated flattened foot? And the reason why they talk about pronation, supination there is that your foot position is really a combination of multiple joints. Instead of trying to say subtalar inversion, midfoot, dorsiflexion, and ankle, instead of trying to manage all that, they just say pronation, meaning all the joints have collapsed with gravity. And then they'll say supination, meaning all the joints have resisted or contracted to overcome gravity. That same terminology can be addressed through really any part of the kinetic chain. And they use it a lot in the lower extremity for pronation, supination. And the pronation through the lower extremity is your body collapsing with gravity, or your inability to resist gravity. So if you were to assess an athlete or a client and have them, let's say, do a single leg squat, you could, and it doesn't have to be full squat to the ground like a pistol, it can just be like a slight knee bend. And if you were to see this like femoral internal rotation, tibia internal rotation, the foot pronating or collapsing, and then the leg going into adduction and a little bit of knee flexion, so your body's collapsed with gravity, you would see that there'd be you would assess and say there's some weakness through that kinetic chain, right? As someone starts to squat or fatigue starts to set in, you start to see those knees dive in because of fatigue mechanism and the lack of muscle support. And what can happen with this whole Varus aspect is that when you have a younger female athlete, like the ages of 18 to 25, they've gone through growth spurt, and women, they stop growing longitude, like bone-wise, height-wise, like a year after menstruation starts, right? They hit their peak aspect. And what you're really getting in that 18 to 25-year-old range is the bones have grown, the levers have grown, and the muscles have become weak because they can't maintain that same moment arm or torque production. And so that transition, because when you look at now older athletes, like females older than 30, you don't really see a higher occurrence of ACL strains because they have had that time to really develop the muscular strength to develop that. And so a lot of times the ACL injuries aren't so much from this Q angle that we've been talking about, but because of this weakness through the musculature from just lack of development. And this is totally manageable through this whole like Varus condition. And again, it's coming from this hip adduction that's causing the knee internal rotation, femoral internal rotation, and grinding on those two connective tissues. So anyways, that's the Q angle. And again, the textbook definition is just this angle from, if you were to look at the midpoint of the patella and you look at the ASIS, right, that anterior superior iliac spine, and you look at the bisecting line that's perpendicular right through the tibia, that angle is going to be about, I think, 12 degrees for men and like 13 to 15 degrees for females. I don't have that numbers memorized. Let's see if they're up here somewhere. Yeah, so just wider in females than men. Again, attributed to increase in ACL or meniscus or medial collateral ligament tears, but it's really attributed to muscle weakness. Okay. So you can see a lateral view here. You can see the patella, and there are actually two joints in the knee. There's the tibia femoral joint, so the articulation between the tibia and the femur, and then there's the patellofemoral joint. And the patellofemoral joint really isn't a load-bearing, it's loaded, but it's not really a load-bearing joint or functional. People could function without a patella. You could surgically resect that, or if there's cancer, but what the patella does, it doesn't necessarily facilitate motion in terms of movement occurring there. What it does is it acts as a anatomical lever or pulley for the quadriceps or the knee extensor group to be able to do knee extension. I don't know if you remember when we talked about the supraspinatus function with the humerus, that if the deltoid So if you remember, we had the scapula and the deltoid, and if the deltoid pulled on the humerus, it was going to pull it straight up in this transitional aspect, and that what you needed was the supraspinatus to come on a little bit so that you could do humeral abduction, or you need the anterior delta do flexion. Well, in the lower extremity, the same thing. If you look at the angle of pull, and you can see it on the screen here, image B is looking at, if you didn't have the patella there, that angle of pull would just be causing joint compression there and just pull straight up. And you would need something to get that motion started. What the patella does is it changes that angle of pull a little bit. It pulls it out. So the patella, where did my thing go? So instead of jamming up, come on. I don't know what the heck's going on. Well, I can draw on this screen, but I can't draw on this screen. That's weird. Okay. Well, anyways, if the patella wasn't there, that would be jamming up here, but you can see that angle is coming out a little bit, so the line is pulling this out. So you're actually getting what you normally see as knee extension. So it can actually come up and do its job from that position. So the patella just acts as a pulley to kind of change that angle a little bit to allow that to happen. The patellofemoral joint can be a big source of pain and dysfunction for a lot of athletes, particularly high impact, so running, a lot of running and jumping, and especially with a lot of heel strike type components. So a lot of your sprinters usually don't get patellofemoral pain because they're landing more on the front of their foot and transferring loads through the back of the leg, whereas the heel strike, so your distance runners or your just any kind of heel striking volume of running, they're transferring force through the front of their leg, and it's going up through the patellar tendon, and they're getting some issues and pain through here. You're also, any type of muscle weakness that is involving this collapse of the lower extremity, I got to tell you, 9 times out of 10, if you have people with like chronic ankle sprains, or you have clients or patients with chronic knee problems, and then we talked about IT band issues, this is it. And this is going to be your biggest indication. Just doing a single leg assessment, and you're going to see this knee diving in. That's cause for you to look at like your external hip rotators, your glutes, your glute medius, anything that's involved in anti-gravity type situations, anything that's creating hip abduction, knee extension, and external hip rotation. Oh, now it's working. Nice. All right, so we looked at the proximal end of the hip, the femur, when we look at the hip, and you can see here's the greater trochanter, there's your lesser trochanter. That's your common attachment for your iliopsoas. The muscle is coming down from the front here and attaching through there. You had your all of your glute, medius, glute minimus, external, everything attaching through there. And then on the back of it, you had your linea aspera, which is where your adductors came in and where your vastus medialis muscle was originating. So now we're going to look down at the distal end, and you have your two condyles here. You have your medial condyle and your lateral condyle. And your condyles are like these big rocker skis that articulate through the meniscus, and they articulate with the tibia plateau here. And on the outside of here, you have your epicondyle. So you have your medial epicondyle and lateral epicondyle. And just like with the humerus, these were anchor points or attachment points for a lot of the musculature. And the reason why they actually stick out or protrude a little bit is because of the muscle forces that are pulling on there. On the tibia, you have your tibia plateau, your ridge, and you also have an epicondyle. And then right here, you have your tibial tuberosity. And it's like kind of like the deltoid tuberosity, where it's like a little bump that sticks out. And this is your common attachment site for the quadricep muscle. So everything kind of comes down through there, even though it originates above through the patellar tendon and up above in the superior of the patella. I don't have a patella to show you, but there's your patella. And it glides right in between. I got this here. And it kind of glides. It's like a diamond shape with like a little peak, almost like a shield. And it kind of comes to a peak and it kind of fills in right at the condyle here. So it kind of has a nice little track. So think of these condyles as like a railroad track, and the patella kind of glides in and out of that. And this is where you get a lot of the patellofemoral pain, is that the patella, show. So the patella is like the scapula. It's kind of floating there in space. It has no bony attachment to the body. And so it is held in place by the line of pull by all the muscles. And so you have your vastus lateralis, even though they come and they converge down to the same tendon, they don't converge until they're below the patella. But the tendon is up the aspect here. You have the vastus intermedius, you have the vastus medialis, vastus lateralis, the rec fem. And then you have, depending upon how they're pulling, if you have too much medial muscle tension, you're going to pull that patella a little bit to this way. And if you have too much lateral, you're going to pull back and forth. In fact, it's one of those surgeries that are just like a Hail Mary and see what happens. Part of patellofemoral pain, which can be so problematic with athletes, is they do a patellar lateral release. And what they'll do is they'll cut the tendon here to kind of release the tension and allow it to heal back with a little bit more gapping. But it doesn't, it's like the IT band. The IT band's really not the issue. It's the muscles that are pulling on there. The patella tracking in the trochanter groove is not really the issue. It's the muscles pulling on there. And if you never address the dysfunction, what ends up happening is they come in there, just cut it, and hopefully that releases pain. And people are in so much pain that actually changing the architecture of the tendinous or the ligament structure is enough to kind of alleviate some of that. So again, the patella is highly sensitive to the muscle tension or the muscle regulation that's happening on the aspect. And again, a lot of that's coming from this, right? From this poor collapse. And I don't know where this came from, but this was told to me a long time ago before my clinic, is that the knee is really symptomatic to the hip and the ankle. That knee problems are very rarely knee problems, unless it's a structural issue, like a torn ligament's a torn ligament, right? But if you're structurally sound and you're looking for a functional problem, like muscle tension, you're usually going to the ankle to see what kind of forces are being transmitted up through the knee, or you're looking at the hip and you're trying to assess what kind of collapse or abnormal forces are going through there. But the knee is more of a signal or a symptom of either hip or ankle foot dysfunction. And that's I know we've talked about this in the past, is that you don't want to approach the body with these blinders on and say, hey, knee problem, oh, let's fix the knee. That you have to take in consideration the kinetic chain, and that a knee problem can be just a symptom of an ankle or a hip problem. All right. All right, so before we move into the muscles, we'll look at the other structural components of the knee. And you have 4 main ligaments that stabilize the knee. You have your collateral ligaments. So you have a lateral collateral ligament and a medial collateral ligament. This is going to control motion in the frontal plane. And so the medial collateral ligament, if I'm here, the medial collateral ligament is going to be on the medial side. And ligaments don't stretch and ligaments don't generate tension. So all they do is resist force. So if I have a medial collateral ligament on the medial side, that's going to prevent this motion from happening. So that's going to prevent either the, now follow me here, the proximal end of the tibia going in or the distal end of the femur going in. So creating a knee valgus position, or the lateral collateral ligament, which is going to be on the lateral side where my right wrist is at. That's going to prevent the gapping on this side. So that will prevent a knee varus position. So that's the proximal end of the tibia going out or the distal end of the femur going out. Right? So this is a valgus position of the right leg. This is a varus position of the right knee. Now, a varus position of the knee creates a valgus position of the hip and maybe of the ankle. So just keeping track that the varus and valgus are joint specific. Right, so medial collateral ligaments here, that's going to check this motion here. It's going to prevent that gapping from there. And that the way this would be injured is if you're standing and someone comes from the side and hits a blow this way from lateral going medial and creates a force like that, that ruptures that, right? So if you think about most of the sports, more times than not, you're getting hit from the outside in, not from the inside out. But an inside out force would cause rupture of the lateral collateral ligament. So you tend to see medial collateral ligament injuries more than LCL or lateral collateral ligament injuries. The other 2 ligaments is you have the cruciate ligaments, and cruciate means crossing. And so you have the ACL, the anterior cruciate ligament, and the PCL, the posterior cruciate ligament. And the anterior cruciate ligament, the way you keep these memorized is that if you look at the origination on the tibia, the anterior cruciate ligament starts in the front and goes backwards to the posterior aspect of the femur. And the posterior cruciate ligament starts at the posterior aspect of the tibia and runs to the forward part or the anterior part of the femur. So they make this crossing-like aspect here. You can see looking down from a superior view on the tibia, here's anterior, here's posterior. You can see the anterior cruciate ligament starting here and coming back behind the femur, and the posterior cruciate ligament starting in the posterior and coming up in front of the femur. And now what these guys do is, and I have that little video posted in the Blackboard shell and then also integrated in the lecture, where you can kind of see those mechanics of how the ACL and PCL are working. Basically, the ACL and PCL is what's causing the rolling and gliding. So if I'm here in this position and I roll backwards, the femur wants to come back, but it can't because tension. So here's my finger represents the ACL, and it's kind of coming from the front, coming back, and it's coming back behind there. So as it starts to roll back, this wants to come back. The ACL gets put under tension and it pulls the femur forward and keeps it forward. Same thing with extension. As I come up, it wants to move forward, but the PCL is pulling on the femur this way, and it's pulling it back into that position. So this whole arthrokinematics in the sagittal plane for roll and glide is mostly achieved by the ACL and PCL. ACL checking knee extension, knee flexion, and PCL checking knee extension in the closed chain. And then it's the reverse for the open chain. Your ACL injuries are usually due to a hyperextension aspect. So what ends up happening is you're posted and you have so here's the anterior part of the knee and you have a trauma this way. So if I go this way, I'm actually shortening a little bit of the PCL, so there's no risk of injury that way. But I've hyperextended or I've lengthened the ACL and it's gone beyond its elastic limit and it's ruptured. And then PCL injuries, if you think about it, if you think this is coming from this direction, that the opposite direction would be true. Well, we have so much knee flexion that we don't really get that type of injury. Where PCL injuries usually come from is with a knee flex position, and you have some kind of trauma shearing the tibia straight back. And so how this usually happens are passengers in a motor vehicle in the front seat, and they have their knees up, their feet are up on the front of the seat there, and they have a trauma and they have an impact like an accident, and they get jammed into the dash. Their tibia hits there, and the rest of their body weight to forward. That's the usual mode of action for PCL injuries. But just because these are the mode of action doesn't mean that you'll get some freak accident where you have an athlete here and they got hit this way, and because of the way they twisted and turned as they went down, that PCL and the ACL also tore. So those are just your standard injuries. Like the PCL is very rarely injured. Most of the time when you have cruciate ligament issues, it's going to be ACL, then MCL, and then usually the medial meniscus are the ones that are issues. And that's called the unhappy triad. That if you have this posting type injury, it's actually, you're going to get, okay. When you have this type of collapse, especially when it's loaded or you have some kind of external force coming into that, this type of injury usually results in an ACL, MCL, and medial meniscus tear. And that's considered the unhappy triad. So the ACL, the anterior cruciate ligament, the MCL on this inside aspect, because it's gapping, you're collapsing in, so it's putting stretch on that tissue. And then because of that medial condyle being large and coming down in there, it's twisting, and that's where it's loaded. It's ripping that collateral or the meniscus on that side. So that's the unhappy triad. And then you had the structures. We had those 4 collateral ligaments, and the last 2 structures are the meniscus. And you have the lateral meniscus, which is you can see it's a little smaller, and you have the medial meniscus, which is bigger. And these are I forgot how they use the letters, but the O and the C or the O and the D. But the medial meniscus is on the medial side. It's the larger of the 2, and the lateral meniscus is the smaller of the 2 on the lateral side. And these basically form the cups, and you can kind of see. You can see that the condyles of the femur actually have more contact with the meniscus than they do with the actual tibia plateau. And that's by design, right? It's meant to cup the condyles and try to increase that surface area so you have as much stability as possible. Any questions with the architecture and the structure before we move into the musculature? So the only new muscles that are going to be here in the knee are either the monoarticulate muscles that only cross the knee or the biarticulate muscles that cross the ankle of the knee. But as you're going to see a lot of the same or similar musculature for muscles that cross the knee from the hip. And we start with the sartorius, gracilis, and semitendinosus. And remember, they have that common attachment to that medial condyle on the pes anserine of the tibia. So you have the sartorius coming down. That's the hip flexor. That's the one that does the figure 4 muscle. You have the gracilis, which is one of the adductors that does knee flexion. And you have semitendinosus, which is one of the 4 muscles of the hamstring. And it comes down and it attaches that pes anserine. You kind of see here, you can see the 3 tendons coming here cut, and then you can see the semimembranosus. And the semimembranosus, which is the pair to that hamstring, it comes down and attaches in the posterior tibia. Let me see if you have a better view of. No. And let's go to the front here real quick. You can see the quadriceps, so the 3 vastus muscles, and then the rectus femoris, they converge down, and then they attach to the superior aspect of the patella. And that tendon is continuous down through the patella and down into that tibia tuberosity. And you can see how that is linked together. So your muscle belly stops way up here, inches above the patella, and it's all connective tissue, tendinous tissue all the way down here. You can see the gastroc, which is one of the primary ankle plantar flexors, but it crosses the knee joint, and it's a powerful knee flexor. And people, when they think of knee flexion, they always think hamstrings. Gastroc is just as much, if not stronger, knee flexor as much as hamstring are. So when you think of knee flexion, everyone always wants to think and only exclusively think about the hamstring group, but your gastroc, your calf, not your soleus, but your gastroc, both medial and lateral head, they do knee flexion, and the gastroc and hamstring actually are very much involved in this knee stability. And if you take your hands and you kind of grab one wrist and you grab your other wrist like this, if your palms, or they come together, that's your knee joint. That's how the hamstrings and gastroc work. So if you try to pull your hands apart, your gastrocs are hanging onto your femur, preventing it from coming up, and your hamstrings are grabbing onto your tibia, and it's creating that nice locked position. And so that's that force couple that's formed between the hamstrings and the gastroc. So you can see the gastroc's coming up and the tibia coming down. If anyone in here is working out at a gym and you're doing leg curls, play around with leg curls, do leg curls, and you'll find that what you usually do in a leg curl, because of the passive insufficiency that you're creating, is that you tend to dorsiflex your ankle to try to lengthen the gastroc to be able to do more of the leg curl, the knee flexion activity. But if you try to keep your foot pointed in plantar flexion, try doing that, and you will probably curse me out because you'll feel some insane cramping that's happening in your calves when you're doing that. So just play around and you can see, and that's a direct application of passive insufficiency. As you're going into knee flexion, you're shortening at the knee, simultaneously you're shortening the gastroc at the ankle, and you're getting that cramping sensation. So just don't forget gastroc as a knee flexor. And that's all we're going to talk about as a knee flexor. We'll talk a lot about it in the ankle, but it's one of those biarticulate muscles. So in the anterior cavity or anterior capsule of the thigh, you have your knee extensor group. You have your rectus femoris, which is a leftover from the hip. This was a hip flexor, and it originated at the AIIS, and it is one of the 4 muscles that make up the quadricep. The other 3 are the vastus lateralis, vastus medialis, and the vastus intermedius. And they do knee extension. But as I had said earlier, you can see that the tendon, the fibers, the way that these fiber alignment, let me see if this will work now. Sweet. Okay, let's do a different color. You can see that these fibers kind of have this oblique angle, right? And what ends up happening is you can get some of this pull. And if you have an imbalance between the vastus lateralis and vastus medialis, that can change the tracking of that patella. And so when you look at these fiber arrangements, just like you had a medial deltoid, an anterior deltoid, and a posterior deltoid, or a medial glute medius and an anterior glute medius, and an anterior and posterior, although we don't really tease this out, you do have individual neurological divisions of the vastus. You have like a superior division, you have an intermediate, and a distal. And sometimes this is referred to as the oblique fibers, or the VMO, the vastus medialis oblique. And you probably have heard of this before, and this is what they're referring to, is that these real distal fibers down here, when someone has a lateral tracking issue, because that's 9 times out of 10, it's a lateral tracking issue. And what that means is that the patella tends to go this way because of the abnormal forces. You have higher forces here than you do here, right? And so if you have this muscle imbalance, it's going to result in a little patellar tracking. And so they try to do a lot of exercises to try to target in on this VMO, this vastus medialis oblique, to counteract that balance to pull that back in alignment. So if I saw Eric nod his head, and a couple other people, you've probably heard of the VMO or the vastus medialis oblique, but that's what they're talking about. It's not a different muscle. It's just the distal fibers of the vastus medialis that have a direct pull on that patella. So when we look at the posterior aspect, we look at the knee flexor groups, and we have the hamstrings, and you actually have 4 muscles. You have two pairs. You have the semitendinosus and the semimembranosus. And remember, the semitendinosus, it's the one that has the long tendon. So tendinosus tendon that goes down and attaches to the front of the tibia at the pes anserine. And you have the semimembranosus that comes down, and this is the semimembranosus here, and it comes down and it attaches to the medial aspect of the tibia. So the way to look at this is you have semitendinosus, semimembranosus. Those are your medial hamstrings. And then you have bicep femoris. It has a long head and a short head. And those are your lateral hamstrings. And you can kind of, how they have them viewed here is they have deep and superficial. So they have superficial here and deep there. But the let me highlight it here. Let's use black. So semitendinosus and semimembranosus, these are your medial hamstring muscles, right? Semitendinosus is more superficial, but its tendon comes down and around to the front. And then the semimembranosus is going to attach here on the medial aspect as well. So medial, semitendinosus, semimembranosus, lateral are going to be your bicep. And the bicep femoris is almost the same layout as the bicep brachii, except for the it converges down. So the long head of the bicep originates up here across the hip. So it's a hip extensor and comes down and attaches to the posterior aspect of the fibular head right here. And the short head also, it converges down to the same tendon, but it only originates on the femur itself. It does not cross the hip. So you only have 3 of the hamstrings that act as hip extensors, but all 4 act as knee flexors. And so the only one that's not a hip extensor is the short head of the bicep femoris. But remember, biceps are the lateral, semitendinosus, semimembranosus are the medial hamstring muscle. So here's your gastroc. You can see that the hamstring was coming down and attaching down here. So biceps and the semitendinosus, semimembranosus. And you can see that there's a medial and lateral head. So it's really nicely divided here. And you have the medial head, the lateral head. These are powerful ankle plantar flexors, right? These become the Achilles tendon with this, the soleus, which we'll talk about in the ankle, because the soleus originates here, actually up here, and comes down, and it doesn't cross the knee. So the soleus does not cross the knee, but the gastroc does. But a very powerful knee flexor and a stabilizer. And then what happens when you get into a knee flex position, the gastrocs actually come in, and the gastrocs are involved in the internal tibia rotation and external tibia rotation, because they're originating up here on the condyles and they're coming down, and they're actually able to do that, pull that line of pull. So another knee flexor that you probably haven't heard of before is the popliteus muscle. It's a tiny muscle relative to the rest of the knee, but or rest of the lower extremity. But it's like a hip, one of the shoulder rotators. It is involved in knee stabilization, and it is involved in this locking, unlocking mechanism that's called the screw home mechanism. And what I'll show you guys on Friday, or when we do the lab next week, is that when you lock out your leg, when you go into terminal knee, and if you do it right now, you can actually, if you kick your leg out and you look at your knee, when you lock out your knee, you actually do a little bit at the very end, when you get that terminal extension, you do a little bit of external rotation. So if you check that out, what's happening is when you do external rotation, it's because the medial condyle is larger than the lateral condyle. When you get that full extension, it's just that locking mechanism that locks that knee into place. And so your terminal knee extension needs to have external tibia rotation in order for it to be stable, which also means is that when you go to bend your knee, that you need to kind of unrotate first. You need to do internal medial rotation, the unlocking, to then do knee flexion. Your popliteus is that muscle. So your ability to bend your knee after it's been extended is predicated on your function of your popliteus muscle. So the popliteus muscle, although small, it is very huge, and it's called the screw home mechanism. And like I said, I think I talk a lot about it in the video, but I can just pull it up here real quick. So you can see that the lateral, the medial epicondyle protrudes a little bit more. So there's a little bit more space there. It's bigger. And as you lock out, so you're looking at the front of the knee here. This is the lateral, this is the medial, and the medial condyle is larger. That as you go into terminal extension, you get that little bit of external tibia rotation to accommodate that distance. So you don't really need the popliteus for that. What you need the popliteus is when you go into knee flexion, you need something to be able to turn it a little bit in an internal rotation to keep that joint congruency. So that's the screw home mechanism, is that little bit of external rotation occurring at the end of extension, what's called terminal extension. So terminal extension is just that knee locking. And it's if you're ever dealing with a patient that is post-op knee replacement, that's going to be the last thing that comes back. And you're trying to actually get that. Everyone, if you end up working in an orthopedic setting, you're dealing with knee replacements. Everyone is so hung up on knee flexion. And knee flexion is important because it's an important marker. But what's going to restore function back to the patient as quickly as possible and take them out of pain faster is the actual achievement of terminal extension, the ability to get into that full extended position. And why that's important is that if you are loaded here and you're locked out, when you stand, if you were to stand up and you were in normal posture, your muscles are actually off, right? Your load is actually through the joint. But if you can't achieve terminal extension, you're slightly flexed. In order to maintain your upright posture, you're generating muscle tension, and you are exhausting energy. You are not allowing the muscles to rest, and this accelerates or prolongs the recovery process. So the faster you can get to terminal extension, the faster that they can stand and walk without having to recruit extra musculature and be in pain. So actually, terminal extension is the focus you want to get in those first 2 weeks of recovery. And then you focus on knee flexion, right? You actually do both at the same time, but that terminal extension through the popliteus and through this whole mechanism is key, is important for that. Depending upon if you're closed chain or open chain, we always learn like the gastroc and hamstrings are knee flexors and knee flexors only. But if you're in a closed chain situation, and this would only occur if you're like if you're looking at like some kind of training parameters or using a leg press machine, or you're dealing with some kind of impairment where you have a paralyzation or a spinal cord injury or a nerve injury, that other muscles can kind of compensate for the joint action. And if you think of the closed chain here, the pelvis and the leg here, so the foot's not able to move. If the foot was able to move in like knee flexion, the foot would be moving back this way, and the gastroc would be pulling, and the hamstring would be pulling, and you'd do knee flexion. But if your foot is anchored to the ground in a closed chain and it can't move, what ends up happening is that these muscles are still pulling. Let's clear this out here. The gastroc is still pulling this way, and the hamstring is pulling this way. And hopefully you can see that the resultant forces actually comes backwards. So in closed chain, where the foot's not able to move, it's fixed. So like in a leg press machine or some kind of device where you're kind of stabilizing the upper body, your hamstrings and gastrocs can actually act as knee extensors. Your bicep also can do the same thing. And I know we didn't talk about it in the upper extremity aspect because that's more appropriate to like training and fitness, but people always think that bench press trains like triceps only. But when your hands are fixed and they can't move, when you do a lockout position, your biceps are actually pulling your hamstrings, your biceps are pulling your elbow into extension. Normally your biceps would do this, like smash yourself in the face, but since you're gripped onto that bar, it can't go anywhere. So when you're doing that shoulder flexion, the biceps are actually able to contribute to that. That's why one of the reasons why you're significantly stronger in bench press than you are in like a dumbbell press. Same thing with like a leg press activity. Because your feet are fixed to move or are fixed and they can't move, your hamstrings and gastrocs are acting as usually belt-like stabilizers, but they're acting as an extensor component. So just keep in mind that some of these compensation things can happen, whether you're dealing with an athlete when you're looking at training, or whether you're dealing with like a neurological deficit from a nerve or spinal cord injury. You can get some compensatory mechanisms because of and only muscles that are biarticulate, they cross more than one joint. The reason why these can act as knee extensors is that as this is coming back, it's shortening at the hip, and this muscle is shortening at the ankle. A monoarticulate muscle couldn't do this. So this is I think that's it for the knee muscles, right? We looked at the vastus muscles, the quadriceps, popliteus, and that's it. Perfect. Any questions? Just look at the chapter. It's chapter 19, right? Chapter 19 lab. I mean, I did a lot with the structure with the skeleton today. The only reason why we didn't do the chapter 19 lab was because we didn't do this first. But yeah, it's funny is we actually through the lecture today did a lot of the lab stuff. So cool, perfect. Do you guys want me to do the chapter 19 lab now, or do you want to do the pre-lab and then we can do the? Let's do that. Let's do the pre. Let you guys do the pre-lab. We won't let's overload it, and then we'll revisit it again the next week, and then that allows us, because we've covered so much already. Then what I can do is we'll do hip and knee on, or pelvis and hip on Friday, and then on Tuesday next week we can review the ankle and foot, and then on that lab day for that Friday, I can do the knee, but then we can do like an integrative aspect of hip, knee, and ankle. And then if we need more time for this ankle and foot by itself, we can do that in the following week before the exam. But I think we're kind of good on schedule wise. So here's the next question: Friday at 1 o'clock, or do we want to try to push it a little later to the 2 o'clock or 2:30 to accommodate more people? And again, 1 o'clock is the one that won out for time, so I'm always do at least the one, but I don't want to push it back and then exclude the 1 o'clock people that.
If there was a possibility to make it later, it would probably be better for me because I work on Friday and I'm home by 4.
Well, I wouldn't go that 4 o'clock.
Oh.
Yeah, so you work from like till 4?
I work. Well, I work till 3 o'clock, and then I have to drive home. But
okay.
So 3. I don't know.
Well, I think we were pushing. I was going to push it to like 2:30.
2:30.
Yeah.
All right.
But I'm open to 3. I'm open to 3. Like I said, as of right now, it's at 1. But in the session I did last, let me stop the recording here so this file doesn't get so big.